Hello, this is Kim Burchell. I'm a professor of neurological surgery at the Oregon Health and Science University, and I wanted to present something to you to discuss a condition of facial pain which is frequently misdiagnosed or missed. I have to admit to you that I'm not an expert in this condition, although I have learned a lot about this in the past decade or so. And I think it's important for clinical neuroscientists, such as neurologists and neurosurgeons, to understand this, because this is a condition most allopathic and osteopathic physicians have never been trained in or even heard of during their medical education. It is important for us to understand this condition because this is frequently confused with another facial pain disorder, trigeminal neuralgia. I will attempt to describe this disorder and explain why this is a major problem in the diagnosis of facial pain, given the relative frequency of temporomandibular disorder in comparison to the condition of trigeminal neuralgia. First, let me say that temporomandibular disorder is not a singular condition, but it encompasses a large variety of conditions causing pain and dysfunction in the temporomandibular joint and the associated masticatory muscles. The problem derives from the fact that TMD is the most common oral facial pain condition after dental pain. It is projected to affect about 44% of the global population by 2050. It has a multifactorial etiology and is a condition that most dentists and even allopathic or osteopathic physicians don't either want to treat or know enough about it to treat it. When you consider the fact that trigeminal neuralgia affects about 0.1% of the population, this means that the TMD disorders are at least 1,000 times more common than trigeminal neuralgia. Etiological factors involved in temporomandibular disorders involve biomechanical stress and sometimes trauma, neuromuscular dysfunction, psychological factors including stress and anxiety, and possibly even a genetic predisposition. The anatomy of the temporomandibular joint is relevant to the production of the TMD disorders. It involves the mandibular condyle, which is the head of the mandible, the mandibular fossa and articular tubercle within the temporal bone, the disc, the articular disc within the TMJ, the joint capsule and synovial membrane, as well as supporting ligaments. The masticatory muscles are fundamentally involved in the production of the pain of the temporomandibular disorders, and these include the masseter, the temporalis, the medial pterygoid, and the lateral pterygoid. These muscles are often tender during the physical examination of the patient with temporomandibular disorder and can help distinguish TMD from trigeminal neuralgia. It is worth knowing that TMD can be divided into various classifications, including muscle disorders, disc displacement, inflammatory disorders, degenerative joint disease, and traumatic injuries. The specific diagnosis of the various temporomandibular disorders is best left to the experts, but it is worth knowing that these include these various types of conditions that can produce pain in the face. These include temporomandibular joint disorders, the masticatory muscle disorders, and these overlap with headaches and other facial pain conditions. Aspects of the clinical history that might be relevant include jaw pain, joint sounds, and in particular, limited opening of the mouth. The primary symptoms of the TMDs include pain with jaw movement or palpation of the musculature or joint, painful clicking, popping, or crepitus in the joint itself, restricted mandibular range of motion, and to some degree deviation on opening or closing. The treatment philosophy for TMD pain involves conservative management as a first-line therapy, with surgical options reserved for the rare refractory cases. The diagnosis of temporomandibular disorder involves a very comprehensive medical and dental history, the characteristics of the pain, including the nature of the onset, the duration, the quality and location of the pain, an assessment of jaw function, including range of motion and deviation, and of most importance, in my opinion, it's the palpation of the masticatory muscles and the TMJ. If indicated, more advanced imaging techniques such as panoramic radiographs, CT scans of the temporomandibular joint, and even MRI can be employed. The indications for more advanced imaging would include panoramic imaging for initial screening for bony abnormalities, CT scan to determine a detailed evaluation of the osseous structures of the joint, and MRI for soft tissue and disc position assessment. Some recent advances in diagnosis include biometric systems for tracking this disorder's progression, enhanced imaging protocols for early detection of TMD, digital analysis of jaw movement patterns, and, more recently, AI-assisted diagnostic algorithms. The use of machine learning to assist in the diagnosis of temporomandibular disorder will be featured in another presentation on this YouTube channel. The best treatment principles involved in the disorder involve a multidisciplinary approach, evidence-based intervention, patient education, and self-care with the progressive intervention strategy. Self-care strategies are extremely important in the management of the temporomandibular disorders. These include jaw rest and soft diet modification if necessary, stress management and relaxation techniques, the elimination of parafunctional habits such as teeth clenching and grinding called bruxism, and proper posture training. Pharmacotherapy typically involves the use of nonsteroidal anti-inflammatory drugs, muscle relaxants if indicated, and tricyclic antidepressants to treat the inherent depression that comes with chronic pain. Injectable therapies may also be used, including intra-articular corticosteroid injections. I've seen botulinum toxin help in certain cases of TMD, and rarely hyaluronic acid injected into the joint, or even platelet-rich plasma may be injected to ease the pain of TMD. Dental interventions may also be indicated, including occlusal splints or so-called night guards, stabilization appliances, anterior repositioning devices, but occlusal adjustments are usually not recommended. I am critical of certain clinics that offer expensive splints and other night guards without a comprehensive approach to this complicated disorder. Physical therapy is typically the mainstay of therapy for TMD, and this may include manual therapy, therapeutic exercises, and even thermal therapy. Manual therapy involves joint mobilization and manipulation, soft tissue massage, myofascial release, and sometimes trigger point therapy. Therapeutic exercises involve range of motion exercises, strengthening exercises, postural training, and coordination exercises. Additional treatments which might be employed for a comprehensive approach include cognitive behavioral therapy for pain management, biofeedback training, dry needling, and trigger point therapy, as well as acupuncture. As mentioned earlier, surgical therapy is reserved for patients who fail conservative treatment and have significant continued functional impairment. Minimally invasive surgical procedures might include arthrocentesis, arthroscopy, and some disc repositioning procedures. If a patient requires more invasive open surgical procedures, discectomy, arthroplasty, total joint replacement, or condylectomy may be required. Indications for surgery would include failed conservative management for over 6 months, significant functional impairment, structural abnormalities which clearly require correction, and severe degenerative disease. The best approach to the care of patients with TMD involves patient education and self-care strategies, nonsteroidals, muscle relaxants, and occlusal splint, physical therapy and behavioral interventions, intra-articular injections or botulinum toxin, and minimally invasive surgery if necessary. Evidence-based guidelines support nonsteroidal anti-inflammatory drugs for initial therapy, adding cognitive behavioral therapy to improve pain outcomes. Occlusal adjustments are generally not recommended, and conservative therapy is effective for the majority of patients. In this video, I've attempted to provide an overview of the temporomandibular disorders to highlight the commonality of these disorders and the potential for confusion of diagnosis with other neurological conditions such as trigeminal neuralgia. To gain a better understanding of that disorder, please refer to other presentations on my YouTube page which go into detail about the management of this very important neurological condition. Thank you for listening to this, and my best wishes for your continued management of patients with facial pain.